Communication is the lifeline of a well-functioning team. This module provides strategies and tools to improve the effectiveness and to promote the sharing of information. Improving the quality of information exchange decreases communication-related errors. Before we get started, let's think about how communication plays a role in the following situation. A physical therapist sees a patient with carpal tunnel syndrome. She discussed the case with a physician, and they recommended ice treatment to decrease inflammation. The therapist tells the patient to apply an ice pack to her wrist, but does not provide detailed instructions. Later that evening, the patient is in the emergency room with frostbite to her hand and wrist, and such swelling that her wedding ring must be cut off to prevent loss of circulation. Where did the communication occur in this situation? How would you have handled the communication of this patient's condition, and to whom? Communication is an important component of the team process because it serves as a coordinating mechanism or supporting structure for teamwork. Communication skills interplay directly with leadership, situation monitoring, and mutual support. Team leaders provide guidance through verbal feedback. Effective communication skills are needed to convey clear information, provide awareness of roles and responsibilities, and explain how performance impacts outcomes. Team members monitor situations by communicating any changes to keep the team informed and the patient protected. Communication facilitates a culture of mutual support. It is also important to recognize the patient as part of the team, and to be aware that clinical and non-clinical folks have an important role in impacting the care of the patient. This module focuses on communication. It informs participants about the components of effective communication and how communication affects team performance. The communication module covers two areas: communication delivery and information exchange. Communication delivery includes the intended audience, the mode of communication, whether written or oral, and the delivery technique, which should be clear and brief. Effective information exchange involves 1. Sending techniques, which involve seeking information from all available sources, sharing information before asked, and providing situation updates as necessary. 2. Recurring techniques, which involve analyzing the data provided and synthesizing it into or modifying the existing plan of care. 3. Verifying techniques, which involve checking back information to investigate the intent of the sender. 4. Validating techniques, which involve confirming the intent of the sender orally or in writing. As an unknown author said, communication is a response you get to a message you sent, regardless of its intent. According to Sentinel event data compiled by JACO between 1995 and 2005, ineffective communication was identified as the root cause for 66% of reported errors. One example, an 89-year-old female presents to the hospital with a history of chest pain. Many tests are being run to determine the cause of the chest pain. The patient and her family decide that they no longer want aggressive measures taken and request that the patient's code status be changed to DNR. The night shift documents in the progress note that the patient requested not to be resuscitated. The night shift does not flag the patient's chart, relay the information during shift change, or notify the attending physician. The morning shift does not read the night shift's notes because of several immediate emergencies. The family leaves the unit for breakfast, and upon return they find the staff attempting CPR. The patient is successfully resuscitated, but now lies in a vegetative state. The family is very unhappy and considering legal action. Example number 2. A patient in the emergency department needs a chest x-ray to rule out pneumothorax. The doctor requests that the nurse call for a chest x-ray and assumes she understands his intent of a portable stat. Instead, the patient is transported to x-ray for a standard AP and lateral chest x-ray. This is an example of inadequate verbal communication. Example number 3. In obtaining consent for treatment, an explanation written in sufficient detail in lay terms and at the patient's level of understanding is necessary. One potential outcome of a precompressive lumbar laminectomy is loss of bowel and bladder control. A consent form that states the known risk as loss of function of body organs does not convey the full extent of risk associated with the procedure. A patient who fully understands the risk may choose to forego the procedure. Lack of communication among department staff can lead to failure of 1. Sharing information with the team, 2. Requesting information from others, 3. Directing information to specific team members, 4. Including patients in communication involving their care. Examples of missed communication opportunities include 1. Unavailable or underutilized status boards, 2. Inconsistencies in the utilization of automated systems, 3. Poor documentation, not timed, nonspecific, illegible, and incomplete. Strategies to avoid these pitfalls. 1. Having the right information will facilitate the right action. 2. Directing information to the particular individual you expect to execute the order ensures that it will not be delayed or missed. 3. Remembering that patients and their families are important information sources. In this module, we will discuss additional approaches to eliminate these causal factors. On an annual basis, JCAHO has issued national patient safety goals. For example, in 2006, major additions included the need for standardized patient handoffs. Particular attention should be paid to ensuring that there is an opportunity for asking and responding to questions. It is a part of the goal to improve the effectiveness of communication among caregivers. TeamSTEPPS provides a vehicle through which some national safety patient goals can become actionable. This includes encouraging the active involvement of patients and their families in the patient's care as a patient safety strategy and as appropriate for age and capacity. The rationale for this goal is that communication with patients and families about all aspects of their care, treatment, or service is an important characteristic of a culture of safety. When patients and families know what to expect, they can monitor actions and orders relative to that expectation or plan and detect and interrupt potential or unfolding errors. Fully informed patients and their families can help to avoid adverse events and hazardous conditions. Communication can be defined as the exchange of information between a sender and a receiver. In 1995, Salas and McIntyre more specifically defined it as a process by which information is clearly and accurately exchanged between two or more team members in the prescribed manner and with proper terminology and the ability to clarify or acknowledge the receipt of information. A tremendous body of evidence exists to support the efficacy of good communication skills for effective teamwork. For example, Ken Bowers et al. Found that communication comprises two critical skills: exchanging information and consulting with others. Information exchange was defined by behaviors such as closed-loop communication, which is the initiation of a message by a sender, the receipt and acknowledgement of the message by the receiver, and the verification of the message by the initial sender. Other behaviors include information sharing, procedural talk, and volunteering and requesting information. Likewise, Dickinson and McIntyre found that effective communication required information to be exchanged in a set manner, using proper terminology and acknowledgement of the information received. Some things to consider when communicating. Number 1, the audience. How might your interaction with a lab technician be different from that with a physician? Number 2, the mode of communication. Is it verbal, nonverbal, written, or email? Number 3, standards associated with a specific mode of communication, such as the use of do not use abbreviations, as prescribed by JCAHO. Nonverbal communication requires verbal clarification to avoid making assumptions that can lead to error. The simple rule is, when in doubt, check it out. Offer information or ask a question. Number 4, the power of nonverbal communication, the way you make eye contact, the way you hold your body during a conversation, are signals that can be picked up by the person with whom you are communicating. Although powerful, nonverbal communication does not provide an acceptable mode to verify or validate information. An example: the nonverbal cues of an emergency room physician gives when looking at an EKG would quickly tell the nurse the severity of the situation and might lead to proactive action. Likewise, the nonverbal cues from the nurse's face might communicate the urgency of the situation and the need for interruption to a physician who is with the patient's family members. Visual cues also provide another layer of nonverbal communication. Albert Mehrabian found that there are basically three elements to any face-to-face communication: words, tone of voice, and body language. These three elements account differently for the meaning of the message. Words account for 7%, tone of voice for 38%, and body language accounts for 55% of the message. The use of color coding for assignments, charts, scrubs, orders, and so on can help team members identify the information they need quickly. Nonverbal communication is not, however, an acceptable mode of communication. For safety to exist, the message must be verified orally or be written. Whether sharing information with the team, patients, or family, communication must meet 4 standards to be effective. Number 1, complete. Communicate all relevant information while avoiding unnecessary details that may lead to confusion. Leave enough time for patient questions and answer questions completely. Number 2, clear. Use information that is plainly understood, layman's terminology with patients and their families. Use common or standard terminology when communicating with members of the team. Number 3, brief. Be concise. Number 4, timely. Be dependable about offering and requesting information. Avoid delays in relaying information that could compromise a patient's situation. Note times of observations and interventions in the patient's record. Update patients and families frequently. Verifying requires checking that the information received was the intended message of the sender. Validate or acknowledge. An example: a well-written discharge prescription is complete. It includes medication, dosage, and frequency. Clear, it is clearly written and legible. Brief, it contains only the necessary information. Concise, it is written before discharge and filled when the patient is ready to leave the hospital. Provide information that is brief, yet as complete as possible. Do not over-explain the situation. Be concise. Be clear, plainly understood. Be timely. Looks like it may be a little too late for these penguins. A number of strategies to potentially reduce errors associated with miscommunication or lack of information are listed. These 4 strategies are simple to integrate into daily practice and have been shown to improve team performance. Number 1, situation, background, assessment, recommendation, also known as SBAR. Number 2, callouts. Number 3, checkbacks. And number 4, handoffs. The SBAR technique provides a standardized framework for members of the healthcare team to communicate about a patient's condition. You may also refer to this as the ISBAR, where I stands for introductions. SBAR is an easy-to-remember, concrete mechanism that is useful for framing any conversation, especially a critical one requiring a clinician's immediate attention and action. SBAR originated in the U.S. Navy submarine community to quickly provide critical information to the captain. It provides members of the team with an easy and focused way to set expectations for what will be communicated and how. Standards of communication are essential for developing teamwork and fostering a culture of patient safety. In phrasing a conversation with another member of the team, consider the following: situation: what is happening with the patient? Background: what is the clinical background? Assessment: what do I think the problem is? Recommendation: what would I recommend? SBAR provides a vehicle for individuals to speak up and express concern in a concise manner. Let's review how to properly use the SBAR technique. In this video, the patient's condition has worsened, resulting in a call to the physician on call. Watch the video to see the transfer of information using the SBAR technique.
Hi, Dr. Feldman? Yes, this is Amy from 2 West. I've been taking care of Miss Everett. Well, she's an 82-year-old woman. She was admitted 3 days ago with DVT. She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention. Yeah, she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah, well, no, I checked with her nurse from the last few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale but not uncomfortable. Her coag studies are within the parameters and her blood gas is normal. All other AM labs are normal. She's not putting out much urine and it looks cloudy to me. I'm worried about her. I think she needs to be seen. You want me to order some labs? Maybe send her urine for culture?
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
How did the SBAR technique improve the standoff between nurse and physician? Number 1, the nurse identified herself and the reason she was calling. Number 2, the physician was quickly made aware of Mrs. Everett's deteriorating situation. Number 3, the nurse provided the background of the DVT diagnosis and all current labs. Number 4, the recent assessment of the patient has led the nurse to call the physician with her concerns. Number 5, the recommendation was initiated by the nurse for additional labs and a plan was discussed for future care. Some providers may find making a recommendation difficult, as they attempt not to diagnose but give broader, indirect suggestions that may not provide clear or concise patient information. A call-out is a tactic to communicate critical information during an emergent event. Critical information called out in these situations helps the team anticipate and prepare for vital next steps in patient care. It also benefits a recorder when present during a code or emergent event. One important aspect of a call-out is directing the information to a specific individual.
Dr. Dean, it looks like these decelerations are getting even more severe.
Dr. Dean, do you think we should consider a C-section?
No, not yet, anyway. This looks okay.
Dr. Dean, the baby's heart rate's been in the 60s.
Let's continue to monitor.
It's been like this for 3 minutes.
A checkback is a closed-loop communication strategy used to verify and validate information exchanged. The strategy involves the sender initiating a message, the receiver accepting the message and confirming what was communicated, and the sender verifying the message was received. Typically, information is called out anticipating a response on any order which must be checked back. Example: information call out, BP is falling 80/48, down from 90/60. The sender expects the information to be verified and validated and to receive a follow-on order that must be acknowledged with a checkback.
1 gram of calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
Confirm that 1 gram calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct.
In this video, the pharmacist was the sender, the resident was the receiver. How did they close the loop? The pharmacist said, correct. What communication errors were avoided? Number 1, the pharmacist did not rely on memory to give the correct dosing information. Number 2, the resident wrote the exact dosing instructions to avoid dependence on memory and was able to check back using notes since the dosing was more complicated by dilution. Number 3, similar sounding drug name errors, as well as dosing units of measure errors, are avoided using this tool. When a team member is temporarily or permanently relieved of duty, there is a risk that necessary information about the patient might not be communicated. The handoff strategy is designed to enhance information exchange at critical times, such as transitions in care. More importantly, it maintains continuity of care despite changing caregivers and patients. Handoffs include the transfer of knowledge and information about the degree of uncertainty or certainty of diagnoses, response to treatment, recent changes in condition and circumstances, and the plan, including contingencies. In addition, both authority and responsibility are transferred. Lack of clarity about who is responsible for care and for decision-making has often been a major contributor to medical error, as identified in root cause analysis of sentinel events and poor outcomes. JAGO National Patient Safety Goal 2E requires facilities to implement a standardized approach to handoff communications, including an opportunity to ask and respond to questions. The rationale is stated by the Joint Commission. The primary objective of a handoff is to provide accurate information about a patient's, client's, resident's care, treatment and services, current condition, and any recent or anticipated changes. The information communicated during a handoff must be accurate to meet patient safety goals. A proper handoff includes the components listed on this slide. Responsibility. When handing off, it is your responsibility to know that the person who must accept a responsibility is aware of assuming responsibility. Accountability. You are accountable until both parties are aware of the transfer of your responsibility. Uncertainty. When uncertainty exists, it is your responsibility to clear up all ambiguity of responsibility before the transfer is completed. Communicate verbally. You cannot assume that the person obtaining the responsibility will read or understand written or nonverbal communications. Acknowledged. Until it is acknowledged that the handoff is understood and accepted, you cannot relinquish your responsibility. Opportunity. Handoffs are a good time to review and have a new pair of eyes evaluate the situation for both safety and quality.
Hi Carla, this is Liza Colby, one of the RNs down in recovery room, ready for report on Dr. Daniel's patient, Mrs. Angie Peters. Angie Peters, 54 years old, going to room 416, bed 2 on 4 East. Status post-total thyroidectomy this morning, doing well now. BP 120 over 85, heart rate 80, temperature 37 degrees Celsius, O2 is up to 97% on 2 liters, and pain is 2 out of 10. Surgery was remarkable for a large thyroid, no pre-op issues. She's a Jehovah's Witness, so no blood products, but she is a full code. Her advanced directives are in the front of the chart. We have one safety concern, hypocalcemia. Dr. Daniels, the attending, ordered calcium levels Q12 hours because she's worried about possible hypocalcemia. So monitor pins and needles, muscle cramps, and shortness of breath. You'll need to review these symptoms when she's fully awake. Normal saline IV is running at 100 cc's per hour. Meds are metoprolol, 50 milligram prior to surgery, and we just gave her 4 milligrams of morphine. Urine output is good, Foley's to be DC'd in the morning. I'll let transport team know to ask for you. That is Carla Lopez, right? What else can I tell you? Yes, that's right. You've got all the information right. Good question. There are no known drug allergies.
What were the positive elements of this handoff? Continuity of care was discussed. Pain management was discussed. Medications were reviewed. Plan of care was discussed. High threats unique to Mrs. Peters were announced. Expectations and responsibilities for the handoff were completed. Remember, Face-to-face or in-person handoffs allow you to see the nonverbal communication between you and the receiver for better confirmation that the message has been properly received. I is for introduction. Introduce yourself and your role or job. Include the patient. P is for patient. Name, identifiers, age, sex, location. A is for assessment. Presenting chief complaint, vital signs, symptoms, and diagnosis. S is for situation. Current status and circumstances, including code status, level of uncertainty, recent changes, response to treatment. S is for safety concerns. Critical lab values, reports, socioeconomic factors, allergies, alerts. B is for background, comorbidities, previous episodes, current medications, family history. A is for actions. What actions were taken or are required? Provide brief rationale. T is for timing, level of urgency, and explicit timing and prioritization of actions. O is for ownership. Who is responsible? Include family responsibilities. N is next. What will happen next? Anticipated changes? What is the plan? Are there contingency plans?
Hi, Bob.
Hey, Bart. Is this your idea of putting me on a diet? Because every time I put food in my mouth, I got a new ER case.
No, just trying to keep you busy. Actually, it was Hal that made a good catch on this one.
Tell me more.
Well, this is Eddie Thomas, 56-year-old gentleman with viral cardiomyopathy and frequent episodes of congestive heart failure. We know him well. Today he came in with an acute anterior MI and early cardiogenic shock. We do have his new and old electrocardiograms. He described the pain as ripping, and his history is one of viral cardiomyopathy, not coronary artery disease. So I'd consider squirting his chest to be certain there's no dissection. He's had aspirin and heparin. We're starting integralin, and there's no beta blockade or nitroglycerin on board because of his hypertension. His labs are drawn and pending. So I'm going to sign off. I mean, Hal will be here to make sure you've got everything you need.
Okay, Bart. You have a recurring heart failure patient with new onset atypical chest pain. Electrocardiogram findings are consistent with acute MI, aspirin but no nitro, and labs pending. I got it from here.
So how was I pass the baton utilized in this physician-to-physician example? Transfer of responsibility during shift change, evolving patient condition information, sharing of information for better decision-making between care leaders. Although you may run into communication challenges on a daily basis, there are many strategies to assist in eliminating or decreasing those challenges. Challenges may include language barriers. Non-English speaking patients and staff pose a particular challenge. Distractions. Emergencies can take your attention away from the current task at hand. Physical proximity. Personalities. Sometimes it is difficult to communicate with particular individuals. Workload. During heavy workload times, all the necessary details may not be communicated, or they may be communicated but not verified. Varying communication styles. Healthcare workers have historically been trained with different communication styles. Conflict. Disagreements may disrupt the flow of information between communicating individuals. Verification of information. Verify and acknowledge information exchanged. Shift change. Transitions in care are the most significant time when communication breakdowns occur. And the tools you can use: brief, huddle, or debrief, two-challenge rule, S-bar, call out, check back, and handoff. Within this module, we identified some barriers to a team's effective communication. The tools of S-bar, call out, check back, and handoff were introduced for your use in communicating more efficiently and effectively within and across teams. As a result, improved communication provides for a safer patient care environment. Good communication facilitates development of mutual trust and shared mental models, enabling teams to quickly adapt to changing situations. Communication is especially important as the environment becomes more complex. It distributes needed information to other team members and facilitates the continual updating of the team's shared mental model and its engagement in other team activities. Team members communicate effectively, sync information from all available sources, verify and share information, and practice communication tools and strategies daily. Communication is an important component of the team process by serving as a coordinating mechanism or supporting structure for teamwork. Communication skills interplay directly with leadership, situation monitoring, and mutual support. Team leaders provide guidance through verbal feedback. Leaders also promote interaction among team members by clarifying team roles and defining team norms for conflict resolution. Effective communication skills are needed to clearly convey information, provide awareness of roles and responsibilities, and define how performance impacted outcomes.